Good day, everyone. My name is Katina McNabb. I am a student at Franklin University. My professor is Dr. Gail Bullum, Nursing 810. Today is July 5th, 2026. Today is my signature assignment presentation, PowerPoint presentation. The title of the presentation, PowerPoint, is Strengthening Onboarding Reliability and Equity by Design for an Outpatient Community Mental Health Service. My presentation focused on strengthening reliability and equity by design in an outpatient community mental health service. The purpose of this analysis was to collectively, as a team with the clinical operations administrator and the director of nursing, was for us to look beyond orientation as a single event and examine onboarding as a system process that affects staff readiness, patient safety, workforce retention, and equitable care. There was a gap and SWOT analysis we conducted that helped clarify that the organization does not simply need more education. It needs a more reliable process that prepares new staff consistently and makes culturally and linguistically responsive care part of the daily process. Effort. In the gap analysis, we saw what the current state revealed and the desired state. The current state revealed variable preceptor preparation, orientation time not consistently protected, interpreter and language preference workflows underused, limited stratified reporting by language, unit, or race and ethnicity. The desired state would be standardized onboarding reliability bundle, competency-based preceptor training, interpreter first and language preference prompts, dashboard review of retention, incident, no-shows, and access patterns. And why does this matter? The gap is not only training, it is a reliability problem that affects staff confidence, retention, communication, patient safety, and equity. The 70% target onboarding reliability will consist of within a 6 to 12 month period. Our goal is 85% target preceptor assignment and preparation with the 90-day early turnover and safety event review window considered. In the SWOT analysis, that is where we would prepare the readiness for change. In a SWOT analysis, you have to consider it consists of strengths, weaknesses, opportunities, and threats. The strengths we found are leadership awareness, existing onboarding policies, huddles and EHR infrastructure, staff commitment to access. The weaknesses were inconsistent onboarding, variable preceptor preparation, limited bilingual capacity, interpreted underuse, and burnout risk. There are opportunities we detected: onboarding bundle, microlearning and simulation, equity by design prompts, stratified dashboards, and audit feedback. You have to always consider the potential threats: persistent vacancies, competing initiatives, poor data quality, variable adoptions across shifts and unit. The synthesis from the SWOT analysis: the organization has enough leadership awareness infrastructure to begin, but sustainment depends on narrowing the change effort. Onboarding should become the operational backbone that also supports equity and retention. The interprofessional team role: nursing operations, HR, informatics, quality, and frontline preceptors share ownerships of one standard process, one measurement plan, and one feedback loop. The proposed intervention for change will consist of an integrated change package, which will consist of standardized onboarding and preceptor checklists, protective orientation hours, and a 30, 60, 90-day reviews. Interpreter first EHR, electronic health records, prompts, and language preference documentation, cultural humility, trauma-informed care, and de-escalation micro-learning, weekly audit feedback, dashboard for retention, incidents, no-shows, and interpreter use. The inspective improvement would consist of a reliable onboarding system should improve staff retention, role clarity, psychological safety, retention, interpreter use, and visibility of inequities. The goal is to make a safe and equitable practice easy to perform consistently. My proposed intervention is an integrated change package. First, the organization should implement a standard preceptor checklist. Second, orientation hours should be protected and structured, 30, 60, 90 review. Electronic records should include language preference documentation and interpreter first prompts. Fourth, humility, trauma-informed care, and de-escalation should be reinforced through short micro-learning and simulation. Finally, leaders should review weekly dashboards that track onboarding reliability, preceptor assignments, early turnover, safety events, no-shows, and interpreter use. In closing, the main insight from this analysis is that onboarding reliability is the operational backbone for a broader improvement. When staff are welcomed, trained, supported, and measured consistently, the organization is better positioned to improve retention, reduce risk, and deliver equitable care. The strongest attempt will begin with one standardized onboarding process, measured closely, and use feedback from staff and patients over time. My references are below that supports the evidence-based practice that I use, and this concludes my PowerPoint. Thank you for your time.